I want you to picture a scenario. It is 6:00 a.m. The coffee is barely kicking in.
Oh, yeah, way too early.
Right, way too early. You are a surgeon, you're scrubbing in, and the water is hitting your hands. You got a patient on the table in the next room who, just found a lump on their leg a few weeks ago.
It's the kind of morning that really starts with a pit in your stomach.
Exactly. Because it seemed harmless at first, maybe just a sports injury or a weird bruise, but it turned out to be cancer.
And now your job, the whole reason you are standing there, is to get that cancer out.
But here is the catch. And it is a massive, high-pressure catch for you as the surgeon. You can't just go in there hacking away to be safe. You have to remove every single microscopic cell of that tumor, but you also have to save the patient's leg.
Yeah, you need to save their ability to walk, to run, basically to actually live their life.
It is an incredibly high-stakes environment. We are stepping into the world of orthopedic oncology today.
And in that operating room, you aren't just asking, what is this lump? You're asking, exactly where is the boundary? What muscles is it invading? Is it wrapped around the nerve that controls the foot?
And how do I navigate this absolute minefield without causing a permanent disability?
That is the tension we are stepping into.
Yes, so welcome to our deep dive. Today, we are looking at a document that, well, on the surface, it looks like a pretty dry technical checklist.
Oh, for sure. It's titled MRI of Soft-Tissue Tumors, What to Include in the Report.
Right, published in the journal Radiographics by Jeffrey Riley and his colleagues. But you and I both know from reading this.
It is absolutely not just a checklist.
It really isn't. When you actually sit down and read through this, it feels way less like a medical form and more like a tactical map for a war room.
That's a perfect analogy. It's the intelligence report that decides the battle strategy before the first shot is even fired.
So for you listening, think of this deep dive as a backstage pass. We are going to decode the secret language that radiologists use to guide surgeons.
We're going to see how a simple black and white image on a screen completely determines whether a patient needs plastic surgery, heavy radiation, or, potentially an amputation.
And so what here is just huge.
Yeah.
Because if this map is wrong, if the radiologist misses a detail by even a few millimeters, the surgery fails.
It fails completely.
So let's unpack this. We need to know who we are fighting. Who is the enemy here?
The enemy is usually a soft tissue sarcoma. Now, these are actually quite rare. They make up only about maybe 0.7 to 1.5% of all adult cancers.
Which is good.
It is good they aren't common, but they are incredibly tricky to deal with.
Tricky how? Like they're hard to find on a scan.
Tricky because they are heterogeneous. That's just a fancy way of saying they can arise from almost anywhere. Muscle, fat, nerves, blood vessels, fibrous tissue.
So it's not just one disease.
No, it's a whole family of bad actors. And they don't always behave the way you expect cancer to behave.
So it's unpredictable. And I assume the surgeon has one main goal when they go in?
Yes, the prime directive is to obtain free margins.
Okay, free margins. We hear that term on medical dramas all the time. Did we get clean margins right? But what does that actually mean in a physical, real-world sense?
Think of the tumor like the yolk inside an egg. To get a free margin or a negative margin, you want to remove the yolk entirely encased in the white without ever breaking the yolk.
You need a buffer.
Exactly, a buffer of healthy, normal tissue all the way around it.
Because if you break the yolk...
If you cut into the tumor, or even if you just peel it out right on its very edge, you leave microscopic cells behind. We call those positive margins.
And I'm guessing that's bad news.
Very bad. If that happens, the cancer is highly likely to come back. And if a sarcoma comes back, the prognosis for the patient gets much, much worse. It's so much harder to treat the second time.
I think there's a common assumption, or at least I had this assumption, that if you have a massive, dangerous tumor in your leg, the doctors just amputate.
Life over limb, right?
Right, take the whole limb to be safe.
Historically, yeah, that was true. Or they would do what is called a radical resection.
Which means
taking the entire muscle compartment, basically removing everything from the bone all the way to the skin in that section of the leg.
wow, that is extreme.
It cured the cancer, sure, but the functional loss was massive. You are taking out the engine of the leg.
But that's not the default anymore.
No, thankfully. Today, because of much better MRI imaging and radiation therapy, the standard is limb salvage. They perform a wide resection.
Meaning they get closer.
Right, they cut close to the tumor to save the limb's function, but they stay just far enough away to get that clean margin.
Which sounds like walking a literal tightrope.
It absolutely is. It requires extreme precision. You can't just guess where the tumor ends. You need to know the boundaries down to the millimeter.
And that is exactly where our source material comes in.
Yeah.
The radiologist has to look at the MRI and answer very specific questions to build this map.
Right.
And the first item on their tactical checklist is anatomy and location. But the paper really emphasizes that this is way more than just saying, hey, it's in the thigh.
Oh, it has to be way more specific.
Yeah. Why is the specific geography so critical?
Because the human body isn't just a big bag of meat. It is highly organized into compartments. Think of a submarine. It has watertight bulkheads.
Right. So if one section floods, the whole ship doesn't go down.
Exactly. Your muscles are wrapped in this tough, gristly tissue called deep fascia. That fascia, along with the bone, creates natural compartments.
Oh, I see.
Usually, a tumor starts inside one of these compartments and stays trapped there for a while. The fascia acts like a physical barrier.
So the radiologist has to look at the barriers first and foremost.
They have to report, is this intracompartmental, meaning it's contained within the bulkheads? Or is it extracompartmental?
Meaning it breached the fascia.
Exactly. Has it broken out?
Why does that distinction change the surgery, though? Because you are cutting it out either way, aren't you?
It totally changes the scale of the invasion.
Yeah.
If it is contained, the surgeon can just remove that specific muscle group and the barriers are intact. But if it's extracompartmental, say it has broken out into the skin or into a joint space, the surgical plan just explodes in complexity.
Give me an example of how that conversation changes in the war room.
Well, if the report says it extends into subcutaneous tissue, which means it has invaded the fat right under the skin, the surgeon can't just stitch the wound closed after removing the tumor.
Because there's no skin left.
Right. They might need to call in a plastic surgeon to do skin flaps or a graft to cover the hole.
So just one line in the report triggers a call to a totally different surgical department.
Immediately, it changes the team, the time in the operating room, the recovery, just everything.
Now, speaking of location, there's a specific term in the source material that I found really fascinating, the split fat sign.
Oh, yeah.
It sounds like a wrestling move or maybe a dessert, but it is actually a visual clue on the MRI.
It is, and it's a great example of how radiology has evolved over the years. On an MRI, fat usually shows up bright white. The split fat sign looks like a distinct rim of fat surrounding the tumor on the top and bottom.
And what does that tell the team?
Well, for a long time, there was a huge misconception about this. Radiologists used to see that and think, uh-oh, this tumor is growing right on a nerve.
Like originating from the nerve itself.
Yes, they thought it was a nerve sheath tumor.
Which would be really bad news for that nerve.
Very bad. But the sources point out that this isn't necessarily true at all. The split fat sign really just tells you that the tumor is located between muscles.
Intermuscular.
Right. Rather than inside a muscle.
So it is strictly a location clue, not a diagnosis of the actual tumor type.
Correct. It helps narrow down the list of suspects. If you see that rim of fat, you know the tumor is pushing the muscles apart, not eating into them.
It's a huge relief.
It's a major aha moment for the radiologist. It reassures the surgeon that the tumor might actually be easier to separate from the surrounding muscle.
Okay, let's move to the next item on the tactical map. We know where it is. Now we need to know what it looks like. Size and shape.
Very important.
And specifically, I want to talk about something called the tail sign. This sounded absolutely terrifying to me when I was reading it.
It is honestly one of the most critical things a radiologist has to spot. But before we get to the tail, we have to talk about size. The general rule of thumb in oncology is the 5-centimeter rule.
5 centimeters. That is about the size of a lime. Or maybe a golf ball.
A bit bigger than a golf ball.
Roughly.
It's a lime.
Yeah.
If a soft tissue lesion is larger than 5 centimeters, our suspicion of malignancy, and specifically high-grade cancer, goes way up.
So bigger is usually badder.
Almost always.
Okay, so size matters. But the tail sign implies that shape matters even more. I think most people, including me, tend to think of a tumor as a ball, like a distinct round lump.
And many are. But some cancers, specifically one called myxofibrous sarcoma, they do not play fair.
I'm not even going to try to pronounce that one.
Yeah, it's a mouthful.
Yeah.
But these tumors have infiltrative patterns. Instead of growing like a neat little ball, they grow along the fascia, spreading out almost like roots.
They sneak out of the main mass.
They do. On the MRI, you might see the main mass, the ball, but then you see this thick streak of enhancement extending away from it, running along the connective tissue.
It looks like a tail.
Like a triangular tapering tail, exactly like a comet.
Wow.
And here is the total nightmare scenario for a surgeon. They look at the main lump, they cut it out with a really nice margin, but they miss the tail because it just blends in with the regular connective tissue.
And the tail is cancer.
The tail is viable tumor cells. If you leave the tail, you have positive margins. The cancer grows back, and often way more aggressively.
So the MRI report has to flag this.
It must flag this so the surgeon knows to literally chase the tail and cut it out, even if it looks like healthy tissue to the naked eye. They have to hunt it down based on the map.
That is wild. It is an invisible enemy. And speaking of invisible enemies, I have to bring up the biopsy tract.
Oh, this is crucial.
This was a detail in the paper that I had never considered, and it kind of blew my mind. We are talking about the actual path the needle takes.
Yes. Before you do the big surgery, you have to get a tissue sample to know exactly what kind of cancer it is, right? So you insert a core needle to get a biopsy.
Right. Totally standard procedure. You need to know what you're dealing with before you open someone up.
But think about what happens physically in that moment. You push a needle through healthy skin, healthy fat, and healthy muscle right into a tumor full of active cancer cells.
And then you pull it out.
When you pull that needle back out, you are potentially seeding microscopic cancer cells all along that path.
You're dragging the cancer back through the healthy tissue.
Exactly. The tract itself is now considered contaminated.
So the needle tract is basically a thin cylinder of cancer now. What does the surgeon even do about that? You can't just leave it there.
No, you can't. In the final operation to remove the tumor, the surgeon actually has to surgically remove the scar on the skin and the entire path where the needle went in,
They carve it out.
as a single solid block, along with the tumor.
That perfectly explains why the radiologist needs to document exactly where the biopsy happened on the leg or arm.
It is vital. And it's why the surgeon usually wants to plan the biopsy themselves or coordinate super closely with the radiologist.
Because if you mess up the placement,
If you put the needle in the wrong spot, say you go through a muscle compartment that was totally clean, you've just contaminated that entire compartment.
oh wow, so now the surgeon has to remove a huge chunk of healthy muscle just to get rid of the needle track.
It really is strategic 4D chess. One wrong move with a tiny needle can cost a patient a muscle they need to walk. It's all about protecting the uninvaded territory.
Okay, let's talk about the neighbors. In real estate, neighbors matter. In tumor surgery, neighbors are literally life or death. We are talking about the third rail of surgery: nerves, blood vessels, and bone.
Right. We call these the neurovascular bundles. And third rail is a really good analogy. You do not want to touch them if you can help it.
But these tumors are huge sometimes. They push things around.
Yeah.
How does the radiologist tell the surgeon if a major nerve is safe to touch or not?
We use a specific geometric rule called the 180-degree rule.
Walk us through that. How does that work?
Imagine the nerve is a round pipe. The tumor is a blob pushing against it. The radiologist looks at the cross-section image on the scan. If the tumor is wrapped around the nerve less than 180 degrees, so it's just pushing against it or abutting it, there is good news.
Why is that good news?
Because usually there is a plane of separation. The surgeon can physically peel the tumor off the nerve, almost like peeling a tough sticker off a tube, and save the patient's function.
But if it wraps more than halfway around the pipe?
If it is more than 180 degrees, what we call encasement, the tumor has likely grown directly into the outer layer of the nerve itself.
Meaning you can't peel it off.
It becomes much harder, sometimes totally impossible, to separate them without physically cutting the nerve.
And if you cut the nerve, the consequences are huge.
Depending on which nerve it is, like the sciatic nerve or the femoral nerve, the patient might lose the ability to lift their foot or extend their knee. They might need a permanent brace to walk for the rest of their life.
So that specific geometric finding on the MRI, whether it is 170 degrees or 190 degrees, often decides the functional future of the patient.
It is a staggering amount of pressure on a single image interpretation, yes. The report needs to be incredibly explicit about it.
What about bone? Because I assumed that if a massive cancer is sitting right next to your thigh bone, it would just eat right into it.
Surprisingly, soft tissue sarcomas rarely invade the bone. It happens in only about maybe 5 to 12% of cases, but they do often touch it.
So if it touches the bone, do you have to remove the bone?
Yeah.
Because that sounds like an amputation or a massive reconstruction.
Not always. This is where the anatomy gets really cool. Bones have a skin called a periosteum.
Like an outer layer.
Exactly. It's a very tough fibrous layer. Often the tumor pushes hard against the periosteum but doesn't actually break through. It acts as a shield.
Nature's armor.
Nature's armor. So if the MRI shows the tumor is just touching the bone but hasn't chewed into the marrow, the surgeon can perform what's called periosteal stripping.
which sounds painful just hearing it.
Well, the patient is asleep, thankfully. But yes, they basically peel that outer skin of the bone off with the tumor, leaving the actual hard bone structure totally intact.
Saving the leg entirely.
Saving the structural integrity of the leg, yes. And the MRI guides this massive decision by looking for fat planes.
Fat planes. Again, with the fat. Fat is really the hero of this story.
Fat is our absolute best friend in radiology because it provides contrast. A fat plane is just a thin line of fat between structures.
Lit up a border.
Exactly. If the radiologist sees a preserved fat plane between the tumor in the bone or the tumor in an artery, it acts as a safety buffer.
It tells you it hasn't crossed over.
Right. It tells us the tumor is close, but it hasn't invaded yet. It's the green light for the surgeon to try and save that structure.
It's like the demilitarized zone. As long as the fat line is there, the border hasn't been crossed.
Precisely. If that fat plane is obliterated, then we really worry about invasion.
So we have location, we have the tail, we have the neighbors, but the source material also warns about dissection. There are ways the MRI can trick you, or rather, ways the tumor can trick the radiologist.
Two big ones stand out in this report. The first is the necrosis trap.
Necrosis means death, right? Dead tissue.
Yes. These tumors can grow incredibly fast. Sometimes they grow so fast that they outstrip their own blood supply. The center of the tumor literally starves and dies.
It just rots inside?
It turns into liquid or dead tissue.
Gross. But why is that a trap? I would think dead tumor is good tumor.
It's a trap for the diagnosis. Remember we talked about the biopsy earlier?
Right, the needle.
If a doctor looks at a massive tumor and sticks the needle right into the center because that is the biggest, easiest target, they're just going to suck up dead soup.
Which tells the pathologist absolutely nothing.
Nothing at all. The pathologist looks at it and says, I can't diagnose this. It's just necrotic debris. You need live cells to diagnose cancer.
So what does the MRI report do to fix that?
The report has to specifically direct the needle to the edge of the tumor, the peripheral rim, where the active living cancer cells are feeding.
So aim for the crust, not the filling.
In a manner of speaking, yes. The filling is often totally useless for information.
That makes so much sense. And the second trap brings us back to fat again, lipomas. I feel like most people know someone who has a lipoma.
Oh, they are very common. They are benign fatty lumps. If you have a soft, squishy lump on your arm that just moves around, it's probably a lipoma. Doctors see them every single day.
Usually perfectly harmless.
Usually. But there is a wolf in sheep's clothing called an atypical lipomatous tumor, or a well-differentiated liposarcoma.
Meaning it's bad.
It looks like fat, it acts like fat, but is a low-grade cancer.
That is scary. How do you tell the difference if they both just look like fat on the scan?
The source material gives us the clues to look for. You have to play detective. If the lipoma is huge, like over 10 centimeters, that's a red flag. If it is deep inside the leg muscle rather than just sitting right under the skin, red flag. Or if it has thick internal lines called septa.
So if you see those signs, you can't just brush it off and say, it's a lipoma, go home.
No, you absolutely cannot. You have to trigger genetic testing. Specifically, they look for something called MDM2 amplification.
Which is what?
It's a genetic marker found in the cancer, but definitely not in the benign lump.
And what if the radiologist misses that? If they just write lipoma on the report and move on?
Then the surgeon might just pop it out in a minor procedure without getting those wide, clear margins we talked about. They might shell it out.
And leave cancer behind?
Exactly. Then it grows back. Or worse, it can transform over time into a higher grade, much more aggressive cancer.
So the radiologist has to be slightly paranoid.
Highly vigilant. They have to look at a benign fatty lump and ask, is this too big? Is it too deep? Is it hiding something?
You know, this whole deep dive has really shifted my perspective. I always thought of the surgery as the main event. You know, the surgeon is the hero, the lights are bright, cutting out the bad stuff.
It's definitely the dramatic part.
Right. But reading this, it feels like the surgery is just the execution of a plan that was actually written in the dark room of the radiology department weeks earlier.
That is exactly how you should look at it. The MRI report is the bridge. It connects the static image on a screen to the dynamic, bloody reality of the operating room.
It's the blueprint.
It determines if the incision is vertical or horizontal. It determines if the patient needs radiation before surgery to shrink the tumor or after surgery to clean up. It determines the entire reconstruction.
It really is the difference between walking out of the hospital or, well, a much different, harder outcome.
And we really have to remember the human element here. We are talking about millimeters of tissue.
Tiny margins.
But those millimeters are the difference between a patient being able to pick up their grandchild or run a 5K, or simply walk down the driveway to get the mail. The radiologist is guarding those functions by drawing that map so carefully.
It puts a lot of weight on the phrase clinical correlation recommended. I feel like I usually gloss over that line when I see it in medical papers.
It's totally a cliche in medicine, sure. But in this specific field of oncology, clinical correlation literally means a sit-down meeting between the surgeon, the radiologist, and the pathologist.
The War Council.
Exactly. They look at the images together, they argue about the approach, they plan the attack. It is the ultimate team sport.
I want to leave you, our listener, with one final provocative thought that really stuck with me while reading this paper. We always talk about what the surgeon removes.
Right, they removed a 10-pound tumor, they removed the cancer.
That's the headline. That's what everyone focuses on. But this deep dive makes it incredibly clear that the most important part of cancer surgery isn't what you take out.
It is what you leave behind.
Yes, the concept of the invisible margin. You can take out 99% of the tumor, but if you leave that one microscopic tail or that one contaminated biopsy tract, or even just one scraping of cells on the nerve, you haven't won.
The cancer will exploit that.
Exactly. The confidence to stitch the patient up and close the wound comes from knowing, entirely because of that radiological map, that what is left inside the body is 100% clean.
And honestly, that is how a surgeon sleeps at night, by trusting the radiologist's eyes.
A truly fascinating look into the war room of orthopedic oncology. Thank you so much for walking us through this complex tactical map.
My pleasure. It is a really powerful reminder of the extreme precision required to save a life.
Absolutely. So next time you see an MRI image, remember, it's not just a picture, it's a battle plan. Thanks for joining us for the deep dive. We will see you next time.